It is so nice to see all of you again, or possibly for the first time if you're joining us today. I know it's been a little while, so thank you for sticking with us. For those of you that have been here before, you've heard our explanation before about this project, but every time we always have new participants. And so I'll do a quick overview of what this group is. We also are going to try not to talk in acronyms, but it's hard, but we'll try. I heard Drake stop himself on one and say it out. So I will try and do the same. But this is Minnesota Project SCOPE. And what SCOPE stands for is supporting children of the opioid epidemic. We focus on neonatal abstinence syndrome, or some may call it neonatal opioid withdrawal syndrome. I talked about that during my first session. We're a community of early intervention providers supporting children and families. And we use the ECHO virtual training model, and I'll quickly cover that. Next slide, please. So what is ECHO? ECHO, again, another acronym. It stands for Extension for Community Health Outcomes. All of us are here today over Zoom, which has become kind of a common thing, right? But when ECHO first started, this was new. And the whole goal of ECHO was to promote health equity and share knowledge and expertise. Share it both ways. Share it from universities and colleges and work with Greater Minnesota in our case, or all around our state, and then also learn from our state and hear what people are seeing out in the field and help us understand. So what we say, it's bi-directional, learning goes both ways. And we really work to provide healthcare without barriers and to really bridge the worlds of healthcare and education. We're a community of practice, so many of us come every time, and then we have time at the end for discussion. Next slide, please. Again, some of the core principles, and I'll be very quick to get to our speaker. We use technology. We talk about best practices. We always have a family story or case study to apply what we learn. And we always collect data. And that's where Drake and all of you come in, where we get feedback from you. So we collect data to monitor outcomes and then further learn what you need from us. Next slide. So today is session 2. As many of you know, we had to rework a little bit. I provided session 1, which was our overview. We have moved Dr. Fran Precker, if you're attending, to November 10th, correct, Drake? I'm saying this correctly. That will be a little more in-depth on neonatal abstinence syndrome. And today we're lucky to have Susan Beaulieu talking about weaving and understanding ACEs, adverse childhood events, and really kind of tie it into our broader mission. And with that, I am going to introduce Susan, who is a wonderful speaker, who we are so lucky to have. I love listening to her, and I'm going to do my best with reading a bio. She has so many wonderful experiences, so I will be reading this. But welcome, Susan. I see you right there. You're under my little Zoom screen, but I'm going to read your bio so everyone gets a little context on you. Susan is an Anishinaabe citizen of the Red Lake Nation and has been working with tribal communities for the past 14 years in a variety of capacities, including project development, training development, and facilitation. She currently works as an extension educator for the University of Minnesota Extension, providing resources and supports to tribal nations and communities around the state on topics including trauma, toxic stress, ACEs, which stands for adverse childhood events, epigenetics, neuroscience, resilience, and healing. So many important topics. Susan is pursuing her PhD in social and administrative pharmacy at the University of Minnesota College of Pharmacy and received her master's in public policy from the University of Minnesota Humphrey Institute. Yay, Gophers, Minnesota. You many different credentials around that. Susan was a 2016 Bush Leadership Fellow focused on learning about generating healing and well-being at the individual and collective levels. She is a mother of 4 and resides with her family in the Brainerd Lakes area. So many wonderful credentials. Thank you so much, Susan. We wanted to welcome you today, and we look forward to hearing you share your presentation. I've heard it before, but every time I do, I learn something new. So welcome.
Thanks so much, Jen. I appreciate being here today.
Thank you. I'm just going to turn it over to you.
Perfect. Thank you. Well, I won't, I guess I don't have to say anything else about who I am. I appreciate the introduction, and I just always appreciate the opportunity to be able to share this information. And so thank you so much for having me here today.
Let me know if you're able to control it. I was able to make you co-host, so you should be able to. If you tap, and then on the bottom left, there's little arrows to advance, possibly.
There are not, for some reason. Like I did see you make me co-host, but then I can see
if you can see it while I'm doing
I can
this.
see yours,
Yeah.
but I don't have access. I'm not sure.
See what I can do.
Thank you, everyone. Technical difficulties, even on Echo. In the age of Zoom, we still have technical difficulties to work out.
How about this now? I just added control to your, there we go.
I think, yeah, I think maybe that works. Okay.
Perfect. Okay.
All right. So for those of you who have ever been in a session I've done before, I always start sessions with some sort of a grounding practice for several reasons. One, doesn't matter how many times I present, I always get nervous. I never, ever could have imagined I would be a public speaker. And so it helps ground me, but it also, we're coming from all of these different things, running and whatever. And so just this helps us to all ground together into this space. So I'd invite you to get yourself into a comfortable position. If closing your eyes feels good, you can close your eyes. Otherwise, just having a soft gaze down at whatever is in front of you. And so we're going to start by bringing our focus to the breath. And as we're breathing in, we're going to breathe in deeply in through the nose and imagining the belly is like a balloon that you're filling up as you breathe deeply in through the nose. And then exhaling slowly out through the mouth, deflating that balloon. And if it's helpful for you, you can think to yourself, soft as you breathe in and belly as you breathe out. To help focus your mind on your breath. Keeping the belly nice and relaxed to let that air come deep into the diaphragm. Activating that vagal nerve, which sends the message up to the brain that you're physically safe. The fact you can take this slow, deep belly breath means you're not running or fighting for your life. And so in this moment, you can relax. We'll take one or two more slow, deep belly breaths. And then before you bring yourself back into the space fully by opening your eyes, I invite you to just take a moment and tune in, noticing how your body feels in this moment, noticing any emotions that might be present, noticing thoughts, and also tuning into your sense of connection to both yourself and to others. And then when you're ready to come back fully into the space, you can go ahead and open your eyes. So I like to start with that too, because I think we often think we have to set aside big chunks of time in order to calm ourselves or our nervous systems. And belly breathing, soft belly breathing, and our breath is one of the most powerful tools we have to regulate our nervous system. And we only did that for maybe 2 minutes, right? So I really encourage you, as you go about your day, just take a moment once in a while throughout your day and pause, tune in. Notice is your breath short and shallow in the chest? That's a good indication you're in fight or flight. We'll talk more about that in a bit. Or is your breathing slow and deep into the body? Nope. Sorry, I'm trying to find the, okay. There we go. So this is the overview for today. We're just going to do a really, really high overview of historical trauma in Indigenous communities in the United States. We're going to connect the dots with epigenetics and intergenerational trauma, and then talk about ACEs. Again, really high overview of ACEs. Then we're going to talk about the nervous system, the autonomic nervous system, those fight and flight responses, the rest and digest, what happens with trauma and that nervous system sort of getting stuck. And then we're going to talk about trauma and the brain a little bit and some resilience strategies. So these are two gentlemen that I've learned an awful lot about trauma in the last couple years, especially. So the guy on the left is Thomas Hubert, and on the right is Gabor Mate. He just came out with a new book, The Myth of Normal. You may have seen him on a variety of media outlets, podcasts and stuff talking about his book. I'd highly encourage. There's actually a podcast he did with Tim Ferriss that's phenomenal, talking about the impact of parenting and trauma on parenting, and then the impacts on kids and how that gets perpetuated. So I'd really highly recommend that. But one of the things that both of these gentlemen talk about, is it, Drake, is it on a timer? Or
No, sorry, I was clicking something else and it accidentally advanced. You're good.
So both of these gentlemen talk about trauma, not necessarily as the event itself, what happens to us, but what happens inside of us as a result of what happens to us. So often, especially when we're children, if we don't have something big and traumatic happens, a traumatic event happens, if our caregivers and those who are around us don't have the ability to help us navigate that experience because they themselves maybe are disconnected from their own emotions, or they aren't able to be there for whatever reason. And often as children, we don't have the tools yet to be able to regulate our own nervous systems. Then that energy of that trauma gets stuck in our systems. It gets stuck in our bodies, can get stuck in thought patterns. It can get stuck as emotions in our body and in our system. And so the trauma really is about that energy that gets stuck in our systems and ends up causing trouble down the road. And also another important piece that they both talk about is that this trauma energy, these patterns, they are potentially thousands of years old. So what we're dealing with today as a collective is really the impact of generation after generation after generation of unresolved trauma within the individuals and the collectives and the collective. And so there's sort of this compounding effect over time. Sorry, I'm used to being able to advance the slides with just my clicker, and I can't find, there we go. Okay. All right, I apologize for the technical challenges today. So this is a slide by Dr. Stephen Porges, and I love this slide. I'm a visual learner, so this really helps me to understand the nervous system and sort of get a sense of where we're at and things we can look for to know what part of our nervous system are we in. So in the green part below, that's what's called the ventral vagal part. And this is where we feel open, curious, grounded. It's easy to be in relationship. It feels pretty good to be in this part of our nervous system. But of course, we know life has challenges, and so there's ups and downs, and that's what you see in that little wave pattern is moving up into the red, that fight flight response, the sympathetic nervous system. And the reality is that as human beings, we like to be challenged. If we were always in the green and we were never challenged, challenge is where we're able to grow, where we're able to learn. Anytime we're learning something new, it's challenging because it's new. So we're going to go up into that sympathetic nervous system. That's just part of life. The problem comes in is when the challenge or the threat is so great that it shoots us further up into that sympathetic nervous system. So sort of the higher up we go, the more activated we get in our systems. And so in the sympathetic nervous system, that's the fight flight response. With that might come emotions, that flight response of panic, fear, anxiety, worry, and concern. And in the fight response, we might have emotions, rage, anger, irritation, frustration. But when we're in this state, we still sort of have this sense of, I can do this, I can figure this out. But if the challenge or threat gets too overwhelming, it pushes us up into the blue area, which is the dorsal vagal part of our nervous system. And this is the freeze or dissociative response. So in this response, we're going to start to check out. There's going to be numbing that happens, both a physical and emotional numbing. We'll talk more about that in a little bit. We might go into a depression, shutdown, shame, hopelessness, feeling trapped. This is the I can't. We feel so overwhelmed and we don't know what to do. This is sort of our system's best response to deal with this type of event is to shut down. And so one of the things I want to mention is that all of this is about survival. So this fight flight response, as well as the dorsal vagal response, helps us to survive as a species. So it's great that we have all of this. And yet when we stay too much in the red or the blue, that's where there become challenges. The other thing I want to mention is that if we do go up into this blue, this dorsal vagal, we don't get to jump from the blue down to the green. In order to come back down into that ventral vagal, we end up going back through the emotions and the energy of that sympathetic nervous system that pushed us into the dorsal vagal in the first place. So what can end up happening is as we go back down through the red, if we still don't have the individual tools to be able to navigate that big energy or the supports around us to help us navigate it, chances are it's going to push us right back up into that blue, into that dorsal vagal. And so then it becomes a cycle where we're cycling in and out of the green and the blue. I think of that sort of as the trauma cycle. If we're cycling in the green and the red, that's more of the challenge cycle. And in that challenge cycle, that helps to build our resilience. But in that fight, flight, dorsal vagal response, that actually keeps us stuck in patterns of trauma. So I want you to just take a moment and pause, think about what do you know about historical trauma as it relates to Indigenous communities, specifically in the United States. And you might want to just pop something in the chat if you have something that you can think of, something that you know is connected to historical trauma related to Indigenous communities. Dr. Maria Yellowhorse Braveheart is the first person who coined the term historical trauma, and she defines it as the cumulative emotional and psychological wounding over the lifespan and across generations emanating from massive group trauma. So historical trauma is different from other types of trauma, either intergenerational trauma or just an individual trauma, in the sense that it's happening to a whole group. It's happening to a collective. And this is really important because as I've thought about and really, as I've really been thinking about and working with trauma and understanding trauma in Indigenous communities, if an individual or even a family within a healthy community experiences trauma, that community is able to support that individual to be able to move through that big energy like we talked about. But if that trauma is happening to the whole community, to the whole collective, who holds the space and helps that community move through that trauma energy? So historical trauma is different in that way. Again, this is just super high overview, but these are some of the things that Indigenous peoples experienced after contact. So things like warfare and genocide, and the estimates that of the number of Indigenous people that were here in the United States and North America varies widely, because of course we didn't have censuses back then, but it varies anywhere from like 5 million up to like 20 or more million individuals. So that was pre-contact. And then around 1900, there were around 250,000 Indigenous peoples left in the United States. So that sort of gives you an indication of how quickly from the time of contact until 1900, that population declined, both because of warfare, genocide, and other things as well. Part of this had to do, of course, with the fact that as Indigenous peoples, we didn't have immunities to a lot of the diseases that came over from Europe. We also have things like removal and relocation, which the removal to reservations, and we don't often hear about very many relocation stories, but one of them that we do hear about often, or we learn about in schools, is the Trail of Tears. And so one of the things that I think is really important when we think about this removal and relocation piece is, so for example, in the Trail of Tears, many of the tribes that were part of that resided originally on the East Coast, sort of southeast part of the United States, and they were removed from there to Oklahoma. And so I don't know how many of you have ever been to maybe the southeastern part of the United States, the Carolinas, Florida, and then also been to Oklahoma. But those are very, very, very different places environmentally, with different plants, different animals, different seasons. And so when a group of people have lived in a place for thousands and thousands of years, they've really built a relationship with the plants, the animals of that place. They know what the medicines are. They know what the foods are, when they can be harvested. They have a really intimate relationship with that place and those non-human relatives that reside there. And so then when they're removed to places where they don't have that relationship, they don't know what's edible, they don't know when things can be harvested, that makes it really hard to be able to provide for your family. And so that really created a dependence, which was intentional, but it created a dependence on the government for supplies, food, annuities, etc. Also, removing of food sources. So some of you probably have seen this picture before. This is a picture of just buffalo skulls. So around 1800, there were around 60 million buffalo that roamed the plains of the United States, and actually even down into the Southwest, which I later learned there were tribes in the Southwest, parts of Arizona, New Mexico, that also hunted bison when those herds would move south. And so 60 million around 1900, and by 1800, and by 1895, there were less than 1,000 bison remaining. And so there were many, many Indigenous peoples that relied heavily on the buffalo for food, shelter, clothing, again, had a really intimate relationship with this animal relative. And so when that food source was intentionally eliminated, it forced a lot of tribes onto reservations. And of course, once they got to the reservations, the conditions were really horrible. Just a quick example, as Anishinaabe people, we traveled seasonally. We had different camps, summer camps, winter camps, berry camps, Menomin camps that we would travel around to. And so that required a lot of land in order to do that. And also so we didn't take too much from any one area. So we were very spread out across Michigan, Wisconsin, Minnesota, into North Dakota, parts of southern Canada. And so really spread out, and then congregating in really small land masses, land areas that didn't have enough food to be able to support us all. And in addition, when you congregate a lot of people in one place, it makes it much easier for diseases to run through populations. So the conditions were really terrible. People were starving to death. They were freezing to death. There was a lot of corruption that was happening with the Indian agents who were giving out the federal agents who were giving out the food and annuities and stuff like that. So the conditions were pretty dire. So boarding schools, and when I think about the impact on Indigenous families, boarding schools are one of the biggest factors. So boarding schools started around 1879. They went through the 1930s. There are still boarding schools today. They're very different than they used to be. But the boarding schools were really, at the time, the federal government had been unable to assimilate the adults, across the Native people, the adults. And so they thought, if we take the kids and we send them to these boarding schools, then we'll assimilate them and then we'll be rid of the Indian problem. And so children, some as young as 3 and 4 years old, were often taken from their homes forcibly. If parents didn't give their children to the agents to be able to send them to boarding schools, they were jailed. Sometimes they were even killed. And so it wasn't optional to send your child to boarding school. Once the child got there, their hair was cut, they got different names, they wore different clothing. If they spoke their language, they were severely punished. All sorts of abuses happened in these boarding schools: physical abuse, sexual abuse, emotional abuse, and neglect. So when we talk about ACEs in just a little bit, you can see just many of the ACEs that happened under the physical and emotional piece were experienced by the Indigenous children that attended there. And so in addition to this, you have boarding schools, you have generations attending boarding schools. So again, this didn't just affect one generation, but it was multiple generations that went through. And we know that we tend to parent how we were parented, right? So when these children in the boarding schools are experiencing these horrible atrocities and things happening to them, pre-boarding schools, things like physical and sexual abuse did not occur in our communities. Our children, many of our Indigenous communities, the language, the words that we used for babies, child, it meant like sacred bundle or little spirit being. We recognize them as sacred beings. And so they were supported and loved, not just by nuclear families, but by really close-knit extended families. Aunties and uncles, the terms for them often meant mom and dad. Cousins, the terms for them was siblings, right? So that's how close-knit the extended families were. So this General Richard Pratt was the first one who opened Carlisle, the boarding school in Carlisle, Pennsylvania. And he says, a great general has said that the only good Indian is a dead one. In a sense, I agree with the sentiment, but only in this, that all the Indian there is in the race should be dead. Kill the Indian in him and save the man. So really the purpose of boarding schools was not necessarily to educate. It definitely was to assimilate. This comes from a bishop from 1875 who says the goal of residential school is to instill in them a pronounced distaste for the native life, so that they will be humiliated when reminded of their origin. When they graduate from our institutions, the children have lost everything native except their blood. And when I read this, one of the first thoughts that came to mind was the research by Brené Brown, who talks about the difference between guilt and shame and how shame is so highly correlated to addiction, to depression, because shame is about there's something wrong with me. There's something bad about me. There's something inherently awful about me. And so that shame then, those overwhelming feelings of shame lead us to coping mechanisms like the use of substances to be able to deal with it. And so we saw that after many of these children left the boarding schools, they turned to alcohol to help cope with what they were feeling and experiencing. Once the boarding schools closed, the sort of taking of Indigenous children continued through the foster and adoption care eras. 1957 and 1967 is sort of the era itself, but I just want to sort of throw out that in Minnesota today, Indigenous children are taken at, the last I heard, it was over 10 times the rate of any other group in the state. So Indigenous children are removed and placed out of home at a significant rate than any other group. And so the taking of Indigenous children continues today. In addition, you have things like the Indian Relocation Act of 1956. It's really hard to see, but on this flyer, it was a flyer that says, come to Denver, chance of a lifetime, great jobs, happy home, training, beautiful Colorado. So it was sort of, as I mentioned, the situation on the reservations was really dire and people were desperate and they were trying to provide for their families. And so you see a flyer like this and the government says, hey, we'll give you money to go to Denver or to go to San Francisco or to go to Minneapolis this. You just have to sign this piece of paper saying that you'll never come back to the reservation, but we'll give you money to get there, and then you'll have all these opportunities. Well, the reality for many people was once they got there, there were no supports at all. There were no jobs waiting for them. There were no homes waiting for them. Many ended up homeless on the streets, and some did try to make their way back. But for many, by this point, they were thousands of miles away from home and no resources to get back. So that's part of why you see really large Indigenous populations in some of these big cities like San Francisco and Denver. So another thing that Dr. Mariella Horst-Bravehart coined is the term historical trauma response. And she says it's the constellation of features in reaction to this trauma, to the historical trauma. The historical trauma response often includes depression, self-destructive behavior, suicidal thoughts and gestures, anxiety, low self-esteem, anger, and difficulty recognizing and expressing emotions. It may include substance abuse, often an attempt to avoid painful feelings through self-medication. So when I first started doing some of these presentations, I remember people saying about our Indigenous communities, like, how come you don't get over it? You know, like that was so long ago. Well, first of all, 1956 wasn't that long ago for the Indian Relocation Act. And it was illegal up until 1979, which is the year I was born. I think it was 1978. I was born in 1979. It was illegal for us to practice our spiritual ways. We could be jailed for that. So it really wasn't that long ago that these traumas happened. And many of these, the ripples of this are still very much felt in our communities. In addition, epigenetics helps us to understand how these traumas continue to get passed down. So epi means to sit on top of. I remember a really robust debate, probably many of you do as well. Is it nature or nurture? The answer now we understand, like most things, is both. Things are very rarely black or white, one thing or another. And so epigenetics helps us understand how the experiences that we have or that our ancestors had, how that influences our genetic code, how it can turn on or turn off genetic code. It doesn't change our DNA, but it changes how our DNA is read. One of the studies that they did that helped them to understand this implication was with mice. So what they did is they took male mice and they had them in cages, and in the bottom of their cages, they had shock pads. And every time that they would infuse the scented cherry blossoms, they would electrify the bottom of the cage. And so pretty soon, over a few repetitions, an association was made between the smell and the pain. They took those male mice, they took out the semen, they artificially inseminated female mice because they didn't want any crossover of behaviors. They just wanted to see what was the genetic impact. And so they took these pregnant female mice, they had their pups, they let the pups grow up, didn't do anything to them. Once they were fully grown, these pups, they infused the scented cherry blossoms, and these little mice went scurrying to the corner of their cages. They were shaking and terrified. They took that second generation, they took out the semen, artificially inseminated another population of females. They had pups, the pups grew up. So this is the third generation now. Scent of cherry blossoms, same terrified response. And not only that, there were more smell receptors in their nose for cherry blossoms, and there had been some changes in their brain as well. So this helps us understand that the experiences that our ancestors have can get passed on through the genetic code. Why? To help us survive. Everything is about survival. And so epigenetics too is about survival, that first generation might not be around to tell the second or third or fourth generations, hey, be careful of this thing. It can hurt you. It can kill you, but it gets passed down through our genetic code. And so we have a reaction to these external stimuli that are similar to the experiences that our ancestors had. And then that activates the stress response in us. Oh, let me step back just for a second. Intergenerational trauma. So this piece speaks more to how the behaviors and patterns within families gets passed down, right? So if I am emotionally disconnected from myself because of the experiences that I had, and I had to shut down emotionally in order to be able to deal with that, when my child is having a big emotional response, if I'm emotionally shut down, I'm not able to attune to them. I'm not able to help them navigate their big emotions. And so what happens? over time, they learn to shut down themselves emotionally because they have no one to help them move through their big emotional responses. So that would be an example of how trauma can get passed down intergenerationally. I know we don't have a ton of time, but I just invite you to just take a moment and sort of check in with yourself. Check in with your body, check in with thoughts and emotions that are coming up for you. And we don't have time necessarily to reflect deeply on this, but I would encourage you to think about how recognizing the experiences of Indigenous people in the United States, how is that important for your work, or how is it important for your personal life? So we're going to shift a little bit now. We're going to talk about ACEs, or adverse childhood experiences. And when I first started teaching about ACEs, we used the pyramid that's on the left, where it started with ACEs, or adverse childhood experiences, which the hypothesis was leads to social, emotional, and cognitive impairment, which then leads to the adoption of health risk behaviors, which then over time leads to disease, disability, and social problems, which then can lead to early death. And so they were able to show through the study that, yep, this hypothesis holds. But as we were out doing presentations in diverse communities, many folks were saying, like Indigenous communities, African-American communities were like, wait, our communities didn't start with ACEs. It started with historical trauma and how that plays out. And so they added some rungs to the bottom of the pyramid to show generational embodiment and historical trauma, which then leads to social conditions and local context, which then leads to complex trauma and ACEs, high allostatic loads and disrupted neurological development, which leads to coping mechanisms, which then over time leads to the burden of disease, distress, criminalization and stigmatization, and then early death. And on the side, you can see things like microaggressions, implicit bias, epigenetics. So all of these things are also factors in this. These are the original 10 ACEs that they looked at under these 3 different categories: abuse, neglect, and household dysfunction. I'm not going to go over them, but one of the things that I do want to say is that these were chosen at the time based on the literature and what they knew. But we also know that these are not the only adversities that can happen to young people. And some places have added additional ACEs like community violence or other things like that. But really, an ACE can be anything that where the child is overwhelmed by the emotions that are coming up because of the experience that they have, and they don't have anyone or anything to help them move through that energy, allow that energy to move out of their body so that it doesn't get stuck in their system. One of the things that they found in the ACEs study is that there's something called a dose-response relationship. So the more ACEs you have, the more likely you are to have negative health outcomes, negative mental health outcomes, poor social health outcomes. So it's not a one-to-one. This was an epidemiological study looking at the population. So it's not like if you take the ACE score thing and you have an ACE score of 8 or 9, you are going to have these things, because there are a lot of other factors that can influence, again, how this impacts us. Did we have folks that could help us be able to move through and navigate what was coming up for us or not? And so you can see here this dose-response relationship. Other ACE attributable problems that they found, everything from substance use issues to obesity, diabetes, heart disease, stroke, COPD. There's a whole host of things that can be attributed to high ACEs. One of the things I want to mention, again, connecting back to unresolved trauma and substance use issues. So in a study that an NIH study, over 2/3 of those in recovery for addiction have experienced at least one ACE, and 97% of the prison population has experienced one or more ACEs. And so one is I think an understatement. Like many of the populations who are in recovery for addiction who are suffering from addiction tend to have significantly higher ACE scores, 4 or more. And that also holds true for folks who end up in prison. Now, as I was learning about these things, I was trying to understand, how do these high ACEs lead to these poor health outcomes or these mental health problems and challenges? And so I also have been trained through the Center for Mind Body Medicine, and I teach a curriculum called Mind Body Medicine. And in that, we were learning about the autonomic nervous system, the two parts of the nervous system, the parasympathetic nervous system, which is our our sympathetic nervous system, which is our fight or flight response. And this is essential in the short term for survival. If we didn't have this part of our nervous system, we wouldn't have survived as a species. And then the other part is the parasympathetic nervous system, that rest and digest. And this is essential for long-term survival. We cannot stay in this fight or flight response too long. It takes a ton of energy from our body, and we'll talk about that more in a minute. So we need to be able to balance these parts of our nervous system, have the sympathetic nervous system for when there are challenges or threats that come up, so our system can be activated and we can survive it. And then we also need to be able to come back down to a state of homeostasis so that our body can heal, we can digest our food, we can sleep, which is really critical for health and well-being. And so as I dug in a little bit deeper into what happens in the body when we go into this fight or flight response, an important thing that happens is we get a rush of adrenaline. And with this, our heart rate increases, our respirations get faster. And this is so more oxygenated blood can go through our body so we can run faster or fight harder. So this is essential for survival. Blood vessels in some of the, in the core and some of the large muscle groups get larger so that more of this oxygenated blood can come through so we can run faster, fight harder. But it shuts down in other parts, in our hands, in our feet. And so you might notice cold, clammy hands when you're feeling, when you're in this fight or flight response. That's because blood is being pulled from those parts of the body and going to what's considered essential parts of the body for survival. Cortisol is released in our system. This shuts down digestion. Digestion takes a ton of energy. And so if we're running or fighting for our life, it literally doesn't matter if we're able to digest breakfast, lunch, or dinner. If we don't survive this moment, it doesn't matter. So digestion shuts down. That energy goes to other parts of the body to be able to help for survival in that moment. We get a dump of glucose. Of course, our body uses glucose as energy. It's sugar, right? So it allows us, again, to run faster, fight harder. And our immune system initially gets a bump, anticipating we might be injured in this when we're running or while we're fighting. But if we stay in that too long, our immune system tanks because our immune system also takes a ton of energy to run, and our body can't simultaneously run the immune system, the digestive system, and the fight or flight response. It's sort of like a, if you've ever plugged in too many things in an outlet and then it blows the fuse, right? Like you can't run all of these things at the same time. Another important thing that happens is our muscles get tight in anticipation of running or fleeing, and our senses get sharpened. Our pupils dilate to let in more light. Our hearing gets more acute. So we're much more sensitive to the things that are happening around us to try and help us survive the threat. But over time, if we're stuck in this too long, it can lead to things like high blood pressure, stroke, heart attack, diabetes, inflammation, digestive issues, and autoimmune disorders. So when we move up into that blue, when you think about, remember that slide, green, red, and blue, if the threat is too overwhelming, we can't run or fight from it, we shift up into the blue, into that dissociative response. And with that, our brain begins to release endogenous opioids and other anesthetic neurochemicals, which numb the mind and the body, because it figures like, hey, since you can't get away from here, you're going to be hurt. Let's make sure you don't feel this as much. Our breathing slows and gets restricted, our heart rate decreases, and our blood pressure can even drop. Again, anticipating if we get injured, we're going to bleed out less fast if our blood isn't pumping really hard and fast. Our body might either go really rigid or limp. Our memory is impacted because our brain is not taking in and processing sensory information in the same way because our senses are getting dulled. So our memory gets impacted. Over time, if we stay in this state too long, it can lead to dissociative disorders, disconnection from body, which I don't know about you, but when I'm not paying attention to when I'm chopping veggies for supper, I'm much more likely to cut myself than if I'm paying attention in my body and noticing what my body is doing. So disconnection from body can lead to more accidents and things like that. And also disconnection from our emotions, which our emotions are a really important set of data and information for us to be able to use. This is just really quickly the handy model of the brain, Dr. Dan Siegel, and this is helpful, and it's really helpful to share with children as well, in understanding what happens when we get what's called an amygdala hijack. So if you would all do it with me, just humor me, imagine that this is your spinal cord coming up here, up the base. This part right here of your hand is the base of your brain. If you fold your finger in, this is your limbic region, your hippocampus and amygdala, and then go ahead and fold your fingers over that. This part right here is your prefrontal cortex, the logical, rational thinking part of your brain. So when information comes in and a threat is detected, this limbic region pops the prefrontal cortex offline. We say you flip your lid. So you no longer have access to the thinking part of your brain. And what takes over is the survival part of the brain. And so it makes it really hard to stop and pause and make good decisions when we go into this fight or flight response and we have an amygdala hijack. Our nervous system is comprised of the brain, the nerves, and all the nerve endings that go throughout the body. And the purpose of the nervous system is survival, is to take in this data and information, help us to process it, and recognize what's a threat, what's not, and how to survive the situation. Our brains are wired through experience. And so at birth, you can see there aren't a whole lot of neural connections. And then you can see by age 7, there's this just an incredible amount of new neural connections that have happened. They call this process branching or arborization, like a tree branching out. So neurons are constantly looking to connect with other neurons. So the experiences that we have make these connections for us. And the connections, the experiences that we have that happen over and over and over again, they get really robust. So we don't even have to think about them anymore. I bet you don't have to think about what side to start brushing your teeth on, or when you get ready in the morning, what you do first, second, third, you just automatically do it, right? So those are those automatic responses. Another important thing that happens is around pre-puberty, our brain begins to prune away those neural connections that aren't very strong and robust because the brain is looking for efficiency. So what remains are those really robust connections. So depending on the experiences that the young person had, if a lot of their experiences were connected to trauma and they didn't have supports for that, though a lot of that neural wiring is what's going to remain, and it's going to mean that they're going to be very easily activated to either go into fight or flight or even shoot up into that dissociative state. I remember hearing a researcher talk about pain, and she said in her lab, they studied pain, and she said, when people were feeling emotional pain, if they gave them Tylenol or ibuprofen, they felt better. Why is this? Because our brain doesn't know the difference between physical and emotional pain. It processes it the same way. And so when we think about traumatic experiences that individuals or groups have had and not had the ability to move through it, that emotional pain remains in their system, which helps us understand why opioids, they work really well for pain. Right. And so again, because our brains don't differentiate between the two, oftentimes people who are stuck in opioid addiction are struggling with unresolved emotional pain that they haven't been able to process. So I know I'm sort of running out of time, but I just, again, want you to take a moment, check in with your body, check in with your thoughts, check in with your emotions. And I invite you to just think for a moment about, why is understanding ACEs and the stress response in the body and mind important for your work? And why is it important for you personally? We often in our work, we're always thinking about how do we help others? But if we are not in tune with what's going on with ourselves, because we are interconnected, I didn't get to get into, the mirror neurons in our brain and all those ways that we are picking up on the energy and the emotions of others, the sort of emotional contagion. But why is this also important for you in your personal life? And how might that impact how you show up in your professional life? So I know I sort of have to blow through this piece pretty quickly, but in the ACE interface, we talk about these 3 core protective systems. So we have the individual capabilities, we have attachment and belonging, those relationships that are closest to us, and then we have community, culture, and spirituality. And all of these pieces influence one another. How healthy and well I am influences how healthy and well my family is, influences how healthy and well the community is, and vice versa. So individual capabilities, this piece speaks to having a positive view, the glass is half full. Gratitude practices are really, really helpful for building positive view. Self-efficacy is the belief that what I do matters, that I have some agency over my life. And so there are practices that we can do that can build that sense of self-efficacy, that can help us be able to set goals, make plans, and move towards it in a productive way. And then, of course, self-regulation, being able to identify where are we in our nervous systems and what practices can we use that can help us to regulate our nervous systems in the moment. Are we in the green ventrovagal? Are we in the red fight or flight? Are we in that blue dissociative state? Just really quickly, these are some tools. A lot of these come from Dr. Bruce Perry, tools that help to regulate and organize the brain. A lot of it has to do with rhythm, pattern. I don't have time to get into that, but it's really fascinating. But these are really helpful strategies for regulating and organizing the brain. And I think I am able to share these slides so these can go out so you have access to these. Attachment and belonging, again, is really important. Children don't come in with the ability to regulate themselves, right? These are skills that they have to be taught. And so they learn how to regulate through the co-regulation with a caring adult. And so again, that's why that piece around recognizing where are we in our nervous systems and helping work with parents to be able to identify where they are in their nervous systems and practices to regulate themselves so that they can be there to help co-regulate with their children. And then there's a lot of really important research that's come out on attachment and attachment theory. And so, again, I don't have time to get into that, but it's really an important body of work that I think needs to be brought into this topic. And then lastly, community culture and spirituality. So again, like where are the places and spaces where people can come together to laugh, to share a meal, to contribute their skills in meaningful ways. These are all, and this spirituality, the recognition that we are part of something much larger than ourselves. So these are all really critical resilience factors. And change requires awareness. It requires consciousness. As long as something remains at that unconscious level, we have no way to change it because we're not even aware that it's happening or that we're doing it. So in order to make change, we have to first be aware of what are our patterns, what's going on, what are our thoughts, what are our emotions in order for us to make the shifts. I wanted to share a resource that we were able to create through a former project that I worked on. We started season 1 there. Last year with season 2, we were able to partner with the University of Minnesota Extension. And right now we're working on season 3. It's called Remembering Resilience, and it can be found on just about any platform, Spotify, Audible, Apple, all of those. So I really encourage you to check it out. All of the seasons, really great information that goes much more into depth in a lot of the things that we talked about today. So just one more time, just inviting you to, I know is a lot of information, lots and lots of stuff, but just taking a moment to tune in again, checking in with your body, noticing thoughts that are in your mind, noticing emotions that are sitting with you. And then thinking about maybe, and then as you continue moving forward in your really important work, thinking about how can core protective systems offset ACEs and the stress response in the body? And why is understanding this important, again, not only for your work, but also for your personal life, for your own health and well-being? So I apologize if I went over at all. Okay. And again, I know that a lot and it was super fast, but it was just a really high overview. But again, for me, understanding all of these pieces and how they're all interconnected is really important. So I wanted to make sure I was able to touch on all of them. Miigwech for your time, and thanks again for having me.
Susan, thank you so much. I'm always amazed at how you take us through a journey of history and connect it to brain development and then further connect it to addiction, and self-medicating and health and wellness, all of that. I feel like I get a semester's worth of learning from 45 minutes with you. So thank you so much. You know, and I in addition, you're getting a lot of thank yous in the chat. I just wanted to sort of pose a question to you and then open the floor for questions. As I shared before, we have a community here of predominantly early intervention providers, but some diversity within that. And if you could give them a takeaway or a bit of learning in their work with families, thinking that they likely will experience both children with ACEs, as well as families with addiction. And sort of just some words of wisdom. And I know I'm putting you on the spot, but that they strategies or thoughts or knowledge they could carry forward in their work.
Yeah, that's a great question. And this healing journey is just that. It's a journey. And for many of us, it starts with awareness. So like for me, I have a very high ACE score. And, when we're in our families experiencing what we're experiencing, that's what's normal to us. We don't necessarily know that it's outside of the range of what's healthy or what's good for child development. And so I didn't realize, this would have been over 8 years ago, because I was pregnant with my daughter, who's now 8 at the time, when I first learned about ACEs, took the ACE score thing and was sort of like, wow, if I don't want to pass these things on to my kids, I need to try and figure out, how do I heal this? How do I resolve this? And so that awareness piece and starting to understand how the experiences that we had when we were young influence the patterns and behaviors that we have today, that really helps to release some of that shame that we might have about being a bad parent, or what we do to our kids when we just react because we're in that fight or flight and we don't have the tools to be able to regulate yet. So helping people to understand how these things are connected, and then offering and connecting them to tools that can teach them how to tune in to what's happening in their nervous systems. And again, like that graphic, the green, red, blue, is a great graphic, and it was really small, but on the side, it shows like all of the things that happen in the body and some of the other things that happen, so that we can begin to notice, oh, my mouth is really dry right now. That's a sign my digestion is shutting down, which is a good sign I'm in the sympathetic nervous system, right? Or my heart is like tuning in, oh, my heart is really racing, or my respirations are really short and shallow. I'm going to take a few slow, deep belly breaths. And then connected to that, and then I'll stop, because I literally could go on and on and on. But then that we offer opportunities for parents and caregivers to practice these skills, so they have them when they need them. Just to say, when your child upsets you, stop and count to 10. That's not possible if we've not practiced the pause. We have to practice the pause. We have to practice the self-regulation when we don't need it, really wiring in, remember, through experiences, those neural pathways are wired in. How do we wire in the slow, soft belly breathing? I do it. I don't even know how many times a day throughout the whole day, right? And so that makes it accessible for me when my kids are fighting and they're in the midst of a throwdown or whatever, right? That I can take a few slow, deep breaths before I try and step in and intervene, so that I'm able to move from a place of response versus reaction.
Absolutely. Absolutely. And I think too, you had so many good tools in here that I think we could even apply in teaching or working with children and families, or to your point, parenting. Who amongst us couldn't do the slow belly breathing with parenting? It certainly tests us. And we can share the PowerPoint, correct,
Yes,
Susan?
Yeah.
I think too, is as we work with children that may come from homes where there's addiction or violence, how can we give them tools? Because certainly, addiction in many ways is self-medicating, and how do we give them another set of tools in their toolbox to cope with stress, to cope with depression, to cope with sadness? And so I just think a lot of what you offered are just helpful toolkits in general in our everyday work. So thank you.
Yeah. Thank you so much for having me.
And I am going to open the floor before we do the case study. Any additional questions, please chat in. You had some nice comments throughout. Susan, I really appreciate it. I probably will launch into our case study. You're welcome to stay, but you're also, it's okay. I know you're busy. Feel free if you need to head to your next presentation or event. You can sign off as well. We'll share your email. It's right here, as you so carefully put. But and you know, people, is it okay if they reach out to you with any additional questions?
Yes,
Okay.
absolutely. Yes, please reach out. Yeah.
All right. Thank you,
Thank you again
Susan.
for having me. Yep.
As always, we appreciated having you.
Thank you,
You
Susan.
take care. Yeah.
Thank
Bye-bye.
you. Thank you. All right. And with that, we will launch, and feel free to reach out to Susan. I can say from experience, she answers your emails and gets back with questions. So if you want to talk to her further, she just is a wealth of knowledge and information about so many things. But right now, I'll start our family story. And I do want to apologize. I am actually at the University of Minnesota Bell Museum on the University of Minnesota campus for an event. And I'm in the quiet room right now, which is not so quiet. There are children running around outside and cheering and yelling. So I hope you can hear me okay. If you can't, we'll turn it over to Drake, but I think my sound's okay.
I think Zoom is actually doing a pretty good job. I can't even tell.
Of filtering it
currently.
out, yes.
So,
And
yep.
those of you who are teachers and in schools or in any environment that has children, families, I'm sure can relate. But I will get started on our family story. This is the story of Lily. I'm not trying to say her last name. Drake, do you know how to say that? And Lily and her family in Bemidji, Minnesota, population 12,000. Next slide, please. Mom, Lily, is 17 years old, lives with her grandmother and mom in Bemidji. They're part of the Red Lake Anishinaabe Nation. Lily is currently in medically assisted treatment since her baby Jimmy's birth. And that means she's getting treatment for substance abuse or addiction. Baby Jimmy, 1 month old, is at Sanford Medical Center NICU due to low birth weight, which we talked, if you remember my presentation, is a very common outcome of prenatal exposure to substances, really any substance. He was born 3 weeks early with a congenital heart defect. He was diagnosed with NOWS, which stands for neonatal opioid withdrawal syndrome. Remember from the first, that for those of you that were in it, and Dr. Precker is going to talk more, but we have sort of dual issues with babies that are born and have been exposed. It's both the exposure, but it's also the withdrawal. They're going through withdrawal, which is a very uncomfortable process. So Jimmy was diagnosed with NOWS, and some of the symptoms they're seeing, poor feeding, poor sleeping, tremors, and some just overstimulation and hypervigilance, common signs that we see in children born with NOWS. Family strengths. We said every family comes with strengths as well as challenges. The grandmother offered to help Lily with the baby. Lily is 1 month into recovery. We know that is very new to recovery. And we also know that while recovery can be very successful, the chance of relapse is high. Lily is studying for her GED online. Baby Jimmy can go home the next month, and Lily holds Jimmy daily at the NICU. So she goes and visits. So this sounds like Lily has been released, but Jimmy stays in the NICU, which we know he's getting services and supports, but we also know from the first one, it's also a risk factor. The longer he stays in the NICU, the more we have challenges around attachment, as well as some other challenges. So I'm connecting the dots across sessions. Some challenges: Lily's mom and Lily's boyfriend, Jimmy's father. The father still uses opioids. The mother is still connecting with him and meeting with him and seeing him. So therefore, there is a risk factor there. Baby Jimmy requires expensive heart surgeries. Grandmother distrusts experts after boarding school trauma. So sounds like related to our presentation. A grandmother has a history on experience with boarding schools. And Lily needs to find a job to support the family. Next slide. Okay, so the breakout group questions are: does Minnesota have services that would be suitable or would not be suitable, considering the family's needs? Do we have culturally responsive services? And I guess what could we do, I guess more broadly, as we always ask, what could we do to support this family? What can we do, especially as we think of it through the lens of cultural sensitivity? We also know some other variables, that mom is new in her recovery journey. So how can we support her? How can we support grandma? How can we support Jimmy?